In this presentation, we're going to be looking at volar plate avulsion/fractures. The anatomy of the volar plate is it is a fibrocartilaginous tissue in the interphalangeal joints. It originates proximally and inserts in the middle phalanx. It is there to prevent hyperextension. Mechanism of injury, though, is hyperextension of the finger or a dorsal dislocation of the finger. The differential diagnosis would be either avulsion or avulsion fracture. Avulsion is a clean tear of the attachment points off of the bone. An avulsion fracture, however, though, is the attachments take a fragmented piece of bone with it, and then you have an avulsion fracture. There's many different classification settings that people use for avulsion fractures and stuff, but the best one I've seen so far is the Eaton classifications. And to get into that is Eaton type 1 is hyperextension with the avulsion of the volar plate and a partial tear of the collateral ligament, which is under the volar plate. Type 2 would be a dorsal dislocation with avulsion of the volar plate and a complete tear of the collateral ligament. And then Eaton type 3 is divided up into A and B. Type A would be a fracture dislocation with a small fragment of avulsed bone from the articular surface. Typically, the differential from type A to type B is whether it is less than 40% of the articular surface or greater than 40% of the articular surface. And so then B would be the greater side of that. See that in the pictures to the right. Signs and symptoms, though, are significant swelling in the joint, possible inability to move the joint, or pain through the range of motion if movement is available, and also a loss of pinching power, so being able to squeeze whichever finger and your thumb together. There are no typical special tests for volar plate. However, if you force them into hyperextension, it could be a sign. There really isn't many predisposing factors. The only one that I could come up with would be past dislocations, just due to the joint laxity at that point. Management of these would be typically just an immobilization of like a splint, usually like you see to the right, or a buddy taping could be an alternative to just taping it to a healthy finger that's next to. The referral process is X-raying is the best way to know whether it is an avulsion or an avulsion fracture or whether the volar plate's affected at all. And then with the referrals, the only time that the splinting and immobilization is not used would be if it's that type 2B fracture, because that is when surgery is going to be needed to fix all the different issues and reattach everything. There really isn't a way to prevent this injury. It could happen in your daily living just by jamming your finger or hyperextending it somehow. There's no Mulligan technique as well. My PCOT analysis looks at 15 patients who had a Eaton type 2B, and theirs was displaced and a rotated fragment of avulsion fracture. All of them had treatment done with a percutaneous K-wire for the reduction of the dislocation, the reattachment of everything. There really wasn't a comparison. It would just be looking at past data of patients that didn't get K-wires. The outcome was no complaints from any patients, no complications. They were all able to return to their required activities, and they deemed it as a successful way to treat a type 2B and making it non-invasive. And then time frame for all this was on average 14 months for each patient. And these are my references.